Hello again, class. Well, we're still going on the CCC system. The first part was I described the terminology and how we got it, and how it represents nursing informatics. The second part, I talked about the information model and why it is considered critical to understand that the CCC is more than a terminology. And now this part, I'm going to illustrate how the terminology and the model are used to document nursing practice. I'm going to take a hypothetical use case using the CCC system for documenting and processing a patient plan of care. My patient, Mr. Jones, was examined in the emergency room with the following symptoms: shortness of breath when walking over 20 feet, acute rib pain when coughing, temperature of 102. The practitioner ordered a chest x-ray and diagnosed the patient as having pulmonary pneumonia, which resulted in being admitted into the hospital. Now, as we know, the first step of any patient admission is to assess the signs and symptoms, which in this case were identical to those of the practitioner in the ERR, and used to determine the nursing diagnoses that the nurse will address in treating and in initiating the patient plan of care. Step 2 is by the admitting nurse in this case where she diagnosed and identified 3 nursing diagnoses for the pulmonary patient. One was breathing pattern impairment, which is a respiratory care component, which is represented by the L. The second was acute pain, which is the sensory component and represented by a Q, and hyperthermia, which is a physical regulation care component. Note, these concepts are always documented with only a 5-digit code starting with an alphabetic letter, which is how the codes are made in ICD-10, and which represent the concept and the terminology coding strategy. As I said, the codes are always in the background of any computer system and are translated and mapped at that point into machine language. In step 3, the admitting nurse next identifies the goal or the expected outcome for the steps for the 3 nursing diagnoses that have been identified as needing nursing services. To improve was selected for the 3 goals. You either say in 3 goals or 3 expected outcome qualifiers. They are both the same. I guess the federal government likes the word goal, and I like the word expected outcome. To improve, and the ANA likes the word expected outcome. To improve, to stabilize, and to support deterioration for each of the 3 identified nursing diagnoses. I think down the road we'll have more data on just what we mean by that, but at this point, we really have the patient in the hospital to improve the condition that they were having in the ER and the condition that they're being admitted and being treated for. In other words, a patient in a hospital always needs nursing care. And because they always need nursing care, we need to use nursing language and nursing terminology to describe our work. This led to steps 4 and 5 for implementing the patient's plan of care. The treatment orders include both the medical emergency orders and the nurse admitting orders. Oxygen therapy, 10 liters continuously, breathing exercises every 4 hours, Demerol every 50 milligrams every 8 hours for pain, and penicillin 500 milligrams every day for the high temp. The PPP orders are transmitted and transcribed similar to the old Cardex, which we used in the past and was prepared and we used in the past for planning and implementing the nursing services and the actions that are combined to treat that patient. But as you can see, for oxygen therapy care, which was to be given continuously, and we are to observe the saturation level for the whole 24 hours, we needed to develop a method of recording this electronically. So what we end up with is monitor oxygen therapy continuously. The breathing exercises is quantified with the action type and is represented by teach breathing exercises every 6 hours with the use of a spirometer. The third one here is I have managed pain control, but you could use manage, but I would prefer to have used perform pain control, and it's to be done every 8 hours. Now, to do this intervention, we have 2 actions. One, administer the pain scale and give the pain medication of Demerol if over 5. And the last nursing intervention was to perform medication administration or medication treatment every day, which means you give penicillin every morning. Now, these 4 interventions and 4 actions provide 2 parts to the service that is provided. And in providing the 2 parts, you will see that the assess or monitor, perform or care, teach or instruct, manage or refer are coded separately and can be processed separately from the rest of the intervention. Now, we do that deliberately because these 4 actions represent and can be used to depict cost and time. If you time these 4 actions, you will then have workload and you will then have cost. And this is so critical to the services we are providing. All services are not provided alike, and all services take different times for different reasons. This gives us the reason we perform a certain intervention. The last step is the actual outcome, which is usually on discharge. It is designed to address the 3 nursing diagnoses that were identified on admission. In this case, the actual outcomes were either improved, stabilized, or deteriorated as followed. Breathing pattern was improved because no more oxygen was needed, and the breathing exercises were discontinued. Acute pain was improved because the patient no longer had a cough and no longer complained of chest pain. And the hyperthermia was improved because the temperature was normal and penicillin was discontinued. Now, that's a very quick and short patient plan of care. And this is pretty much how it would look in the electronic health record. You can either go horizontal or you could go vertical with a date for horizontally for day 1, day 2, and day 3. We've tried them both ways, and the nurses like them both ways, but it will depend on your preference and on how your computer system is set up. So there's a column for each of the 6 steps of the information nursing process. Now, this ends the sample use case, which is coded using the CCC system, in which the codes are hidden from the user and entered in the background and mapped to SNOMED CT. On discharge, the patient summary should include the summary of the nursing process steps, instructions for post-hospital orders, such as follow-up appointments, lists of medications, and referral to home health care to the doctor or to home to continue what's called continuity of care. Here, the PPOC table. Then I have another table here which shows the same table, but it's mapped to SNOMED and LOINC, primarily mapped to SNOMED in this illustration. Now, for your information, the federal government, CMS, has identified SNOMED as the interoperable language for MACRA. Even though they're still reimbursing using ICD codes, they have this MACRA requirement for interoperability that is transmitting discharge orders from one system to another. I think, and I'm not sure, but you should know a little bit about SNOMED, CT, and LOINC. SNOMED is really a reference terminology consistent of thousands and thousands of concepts, very much like a super dictionary. The terminology not only gets at body parts, it gets at code sets, it gets at just about everything that is in healthcare. All of the concepts are also in the National Library of Medicine's Metathesaurus, the Unified Medical Language System, and is free from NLM. So if you have a private practice, you will always have to have access to the National Library of Medicine, and from which you will be able to download SNOMED CT if you need to. You can also download the clinical care classification, which is also in the Metathesaurus of the UMLS. LOINC is emerging as being used for patient histories, and right now it's also in UMLS and in SNOMED. So these terminologies are emerging, and what we're trying to do, or what the federal government, or what ONC is trying to do, is to limit the number of terminologies so we will have some consistency of language and some consistency of interoperability across systems. Here's an example of the CCC map to SNOMED. You can see in the left-hand column is the CCC code called value. The next column is the SNOMED code, and the last column is the definition that CCC has and how it is used and coded in SNOMED. I'm so proud of this because it does get at the mapping that is so critical to make the CCC system the only interoperable nursing terminology, at least the most usable and nursing-friendly and computer-friendly interoperable nursing terminology that we could use to be a part of MACRA. The next segment, which I will talk about, is the analytics of using the CCC coded data for the use case, and I will show you the examples of just what you can do when you've coded the nursing practice and the patient plan of care in an electronic health record system.